I don't think any of us have experienced this type of pandemic that has had such a significant impact on our clinical practices, on our family lives, and on the community and economy at large. And none of us are necessarily have a crystal ball about things, but I'm just curious, in your roles, maybe you can each take a stab at this, is what are your concerns? What are your predominant concerns for either the specialty of oral surgery or for dentistry as a whole? Do you have any observations or concerns that you'd like to share with us or the viewers?
I mean, I can start. I can tell you that the toughest thing that we had to do. I mean, we've got a large group practice here in Toronto. We employ 70 people, and last Monday we made phone calls to about 55 or 60 of them, temporarily laying them off, which was very difficult and something none of us ever thought we'd have to do. So I think from a, you put your hat on as a business person, because for those of us who have private practices, these are businesses, and we're being affected significantly. Us and every other business in the modern economy is being affected significantly. I think what we all need to be doing is taking care of things now, making sure that we're doing what's appropriate now, but also not losing sight for the future, and being planful for when we're on the other side of this, and making sure we're keeping in touch with those staff that are no longer working with us and keeping connected with them, making sure we're ready to be up and running the first day that we can be up and running, which may be tough. There may be PPE resource issues for us to be operating on the other side of this. And so there's a lot, I think a lot of the people who are going to watch this will have those concerns, and it's quite anxiety provoking. I mean, Graham, you guys are in a similar situation with your practice, I'm sure.
Yeah. I mean, personally, I don't think on the other side of this, if there is another side of this, I mean, I will never do another aerosol generating procedure without thinking about what we've just lived through and thinking about the fact that I've historically done procedures with inadequate PPE protection. I mean, there was some references to us going to work with the common cold in the past, and the dread, the retrospective dread that I consider that, if you had a patient come in tomorrow who was coughing and with a sniffle, you probably wouldn't want to even walk into the room to say hello, and you want them out your offices for the sake of everybody around you as soon as possible. So when things are back to normal, it'll be very interesting to see what the PPE recommendations and requirements are for these types of procedures.
I think that once we are on the other side of the COVID issue, that personal protective equipment and the way we practice infection prevention control in dentistry in general is going to change significantly. I think the knowledge that we're gained, that we, and I'm talking collectively, we as in dentistry have gained, could work to inform better patient triage, a better understanding of disease transmission at the community level, and it may also, I'm hoping that it might bring a little bit more rational thought into the way we utilize personal protective equipment. We have found that many people in dentistry believe that if one thing is good, a lot of that thing is better, and this may well demonstrate that those lower level of PPE are perfectly appropriate and far more cost effective in certain situations, but then that it's not one size fits all. And I think that's kind of what has gotten dentistry into hot water recently, is that across the board, regardless of what we're doing, we tend to have a one size fits all approach to infection prevention and control, and to PPE when we're treating patients. And that is not appropriate. It has never been appropriate, but it's just been accepted practice. So I think that out of this, we may see more thought, more education behind infection prevention and control right from the get-go with beginning practitioners, and maybe more supports from dental regulators, in the community for practicing dentists in helping to support infection prevention and control. I consistently, on a weekly basis, get many, many messages from dentists in the community about specific questions about their practices or their way of doing things that they just simply, there aren't the resources for. There's a lot of IPC knowledge in medicine, but there's not a lot of specific IPC stuff in dentistry. For example, I was on a conference call with one of our IPC leads here in the zone, in Edmonton zone, and she initially at the onstart of the conversation said, well, it's just dentistry, it's okay. And so I went into further detail to describe the types of tools that we use, the types, and she's like, well, it's just Droplet, don't worry about it. And I said, no, let me describe to you. We have a handpiece that can spin at 200,000 RPM, and that's aerosolization. And so I don't even know that IPC people in medicine understand the true risks in dentistry. Ergo, we have inappropriate practices for infection control and for donning and doffing of PPE that are specific to dentistry. We're a different entity altogether, and I think that maybe that'll come to light, and we might have greater support. I'm hoping.
So my hope in disseminating this information to the dental and oral surgery community to make every single attempt to medically or conservatively manage any emergency scenario that you encounter, with the exceptions of the ones that we've mentioned. And in those situations where you encounter one of those extreme emergency scenarios, you directly get in touch with the attending staff at an appropriate institution in your community where you know there's an oral and maxillofacial surgery service that's equipped to manage those types of emergencies. And so the message that I tried to send to the dental community and to the oral surgical community is there's a significant amount of history taking that can be done by telemedicine, so to speak. And I think that we should definitely try to use that instrument to try to triage these emergencies and reassure patients about the rationale for the pharmacological or conservative medical management of situations. Especially given that we can now assume, or should assume, that every single patient that we see is COVID positive until proven otherwise. Right. So even in the context of this interview and this conversation that we're having, I alluded to the scenario where clinical practices in the community, using conventional PPE, in other words, non-respirator masks, just gown, gloves, cap, and face shield. Given that information, are we still of the opinion that they can do a procedure that's going to generate aerosol?
We oftentimes lose sight of what actually is occurring in the general dentist's office. And for general dentists, the vast majority of them some of them don't wear scrubs, some of them are still just wearing their shirt and tie. They do not wear overgowns. I have had many conversations with former students of ours this past 2 weeks asking where they can purchase gowns or if they can, sign up for a laundry service. So routine use of any sort of clothing cover in dentistry is not happening. 99.8% of offices will not have any hair covers as well. Most of them don't wear any eye protection or their own prescription lenses, so they won't have safety eyewear. And they certainly maybe have a level 2 or maybe if they're really, really precautious, might have a level 3 mask there, but they certainly don't have N95 masks. So I think that from the grassroots point of view, when we look at giving this guidance, we need to give it in context about what's currently going on in practice. Most dentists go in and they put one mask on and a set of gloves, and they have bare arms and their hair out, and that's how they're providing dentistry. So if we're going to give guidance of saying, yeah, sure, you can go ahead with these procedures, knowing that they're going to wear just a regular procedure mask, a level 1 mask, a set of examination gloves, that is risking their health, but also every single person that they come into contact for the remainder of that day. Yeah. And so I think we have to give this guidance in context within general dentistry, within the hospital, and within oral surgery offices, because they are vastly different in regards to their level of IPC knowledge and practice.
Right. In an ideal situation, the provincial regulatory bodies have attempted to publish lists of clinics that may be suited to treat the population at large for emergencies. Brian, I think, can you make a comment about that, please?
Yeah, so here in Ontario, our regulator has made that request. And I've been in touch today just by a casual email as a member. And I asked them, I said, all right, pointed out two issues. One is the potential lack of resources of PPE that might make most of these clinics unable to provide emergency care. And the second issue is that if we're making the assumption that most patients are going to be COVID positive at some point, N95 masks are going to be required for any aerosol generating procedure that might be required. And the reality is 99.9% of dentists have not been appropriately fit tested. So how do we work around that?
Can you go buy an N95 mask at Canadian Tire? Like where can you, Rana, can you talk to the issue of N95 mask, and in particular the importance of being fitted for an N95 mask and their reusability, please? Can you talk about that issue?
Absolutely. So N95 mask fit testing is based on the size and shape of a patient's face. And the premise of an N95 mask is that it has filtration, and it's only appropriate and it only works well if it is sealed against your testing. What it does, thing that people don't understand is that there's not only one kind of N95 mask. Much of the time we see on television and in the news, people are wearing what looks like a traditional cone mask that we would use in dentistry. And that's not the only size and shape of N95 masks. There are many, many different sizes, shapes, and designs of N95 masks. And the reason for that is because they have to be able to fit a particular shape of nose, a particular profile, particular fleshy cheeks or thin cheeks. And so I think the seal is the important piece, and that's what we accomplish with fit testing. Fit testing is actually done with a hood, and we use, initially you'll use a bitter solution, and then if bitter is undetectable to the person, then we would switch to a saccharine or sweet solution. And the idea is that we put the mask on the patient, on the user, and we spray these either the sweet or the bitter solution inside of this nasal hood, and we test the patient or the wearer to find out if they can taste it. It's actually not a smell test, it's a taste test. And if they taste it, then that mask isn't well fitted for them, and we have to move on to a different one. And so we continue this process until we find an N95 mask that appropriately fits the face of the wearer and protects them from the contaminants that we artificially put in their personal environment from coming into the mask. So if you were just to take an N95 mask, say from Canadian Tire, off of the shelf and put it on, it provides you no more protection than a regular face mask. And the reason why regular face masks are not very good at filtering out environmental pollutants or particles is because they don't seal to your face. They are on the edges of the mask. If you have a tire and ear loop mask, generally are gaping and wide open on the sides, and there's really no point to wearing them. So, and the same goes for an improperly or not fit tested at all N95 mask. And with as far as timelines go, the World Health Organization has just this past week issued some guidance in relation to, here at the school, we often talk about what's best practice. And best practice would be to have a fit tested and when you put it on, fit checked N95 mask for each and every patient that we see. Given our current shortage with PPE, that certainly can occur. And the guidance from World Health Organization and from other regulators is that if you put the mask on correctly, you fit check it when you put it on. So fit checking is the check that I do every single time that I put a mask on to make sure it's sealed well. As long as that mask stays in place and doesn't become wetted from me talking, coughing, sneezing, perspiring on the mask, or it doesn't become wetted from the procedure that I'm doing, that mask can remain in place for the timelines they've given is an extended period. They haven't actually given that timeline. Here in our clinical spaces, we are using one N95 mask per clinician per emergency clinic, and they put it on, they fit check it, and it stays in place for the duration of that 3-hour clinic. And that enables us, of course, we change our overgown, we change our gowns, we change our hair cover, but the actual glasses themselves and the masks themselves are staying in place for that abbreviated clinic time. And this is essentially why we've gone to decreasing the number of clinics we're holding in a week and decreasing the length of those clinics just to manage those truly emergent cases in our clinics.
There was a question or a commentary regarding the accessibility of N95 fitting in the community. Brian, can you talk to that?
Yeah, I mean, I don't know if you'll be able to answer it, Rana, but in a non-COVID time, I mean, what volume of requests did you have for community dental practices to do fit testing? And now, are you aware of the ability for that to happen during the crisis that we're in now? Like, can practices out there, if they want to step up and manage all emergencies, do you think that there's capability to obtain that testing now?
That's a very good question. There are a limited number of industrial supply companies who also offer N95 mask fit testing. And of course, most institutional occupational health and safety groups will offer that fit testing as well. But the dilemma that we run into in this current situation is that in order to be fit tested for an N95 mask, you have to have an N95 mask to be fit tested, period. Not talking about having a mask then to use on patients. So we currently, and since we have been in this situation since the end of January, we've been in contact with all of our suppliers on a bi-weekly basis requesting N95 masks, and all of our requests since the end of January have been denied. We are working with Alberta Health Services to see if there's any sort of a possibility for us to share mask supplies, but most of those communications have come back as, oh, you have N95 masks, and now they want them from us. So I think that the whole issue or discussion around being able to utilize an N95 respirator in the community to provide emergent care is a moot point at this point, because you can't get the mask to be fit tested, and without the mask you can't be fit tested, and there are a limited number of providers. Most of them are involved institutionally, and those of us that are quote unquote freelancers, if you will, that will do it, are otherwise engaged, and we can't fit test you unless you have a supply of N95 masks.
If I'm wearing appropriate PPE, i.e. a mask and goggles and a gown and a hat, what is the degree of risk? And if we assume that everybody in the community is COVID positive, unfortunately, for the sake of safety, what is the risk of somebody that's in perfectly good health of actually acquiring this disease in a non-aerosol generating context? Is there do we think there's any substantial risk of acquiring the disease?
Absolutely. And the science from that comes from, if we look back at the Ebola virus disease in West Africa that was in 2015, and other subsequent Ebola virus outbreaks, where contact and droplet precautions come in, is that the vast majority of healthcare workers who became ill in the process of taking off contaminated PPE, and they contaminate themselves. So most associations, I know that Alberta just published this morning, sent out a letter to everybody with actual links to Alberta Health Services provided posters and videos in relation to how safely to don PPE, but more importantly, in my opinion, how to doff PPE appropriately. Most healthcare workers don't become ill because they are frivolous or careless with the way they're protecting themselves. They're quite well protected. But when you take that contaminated PPE off, because the known modes of transmission for this are droplet and contact, and if you have PPE that are completely contaminated, in that process, it's very, very easy to contaminate yourself.
Rana, can you also just comment on things like, personal clothing? people wearing them in and out of the office versus changing into scrubs in and out of the office, and how those are laundered?
I would strongly advise against that as well too, because when we're talking about droplet and contact, everything that goes into an office or into a procedure and out of a procedure becomes a possible fomite. And so meaning that it could carry the virus out into the environment and contaminate the environment and or yourself. So if you have practitioners who are going into the office and they are going in with a set of clothing and they're treating patients, even if you are wearing PPE, given the virulence of this particular virus, that creates a whole risk profile that really doesn't need to be there. It shouldn't be there. If you are wearing clothing into the office and then you treat patients in that clothing should come off in the office. It should go into a bag. You should put fresh clothing on to leave the office. And once it's in that bag, without touching the items in the bag, it goes into a washing machine with hot water, a little bit of bleach and detergent. So many of the items I tell my students the story about dentists who will go into a practice wearing a tie, and they will see patients. And those of you, I'm not a tie wearer, but I've been told that some ties can be quite expensive, made of beautiful silk. Maybe they're sent to the dry cleaner once in a while if you spill some food on them. But those items are not being cleaned. And so I think that advising individuals to do everything in their power to not carry the virus out of the treatment room is really, really important. From donning the correct PPE, taking the PPE off correctly, but then again, wearing scrubs. I am a strong advocate for wearing scrubs with an overgown over top of those scrubs. That's my oral surgery background speaking. And making sure that those contaminants created by your care with your patient are not carried out into the world, into your family and to your colleagues. That I strongly advise against wearing any kind of streetwear, if you will, whenever you're treating patients.
So I think that's extremely invaluable, very valuable advice. Thank you, Rana. And I guess to get back to the key question that started this discussion is, if you're wearing appropriate PPE and you're examining a patient in a non-aerosol generating context, as you mentioned, the importance is of wearing the PPE and how you remove the protective garments. If that's done correctly, I believe we can probably agree on the fact that the statistical probability of acquiring an airborne or droplet-borne disease is diminished significantly if you follow those guidelines on the donning and doffing of protective wear, right?
As well as making sure that your environment is cleaned and disinfected thoroughly. And so, we could be very careful in taking off contaminated PPE, but then touch a contaminated dental light or touch a contaminated counter, and we've undone all of the work we've just done. So it's IPC is a multi-layered beast, and it's not just one thing. It's the whole collective together that protects you and your patient and your staffs.
Right. Excellent. Thank you for that insight, and it is a bit of an eye-opener when you think about it.
And since I left, it's so dynamic, this thing, we got a policy change that now even to be in the clinic as a house staff or staff, we need to be in level 3 masks in the clinic.
Yeah. Well, they have to be labeled as ASTM level 3. Yeah. So you have to look on the box from the manufacturer, and it'll tell you what the ASTM level of it is, level 1, level 2, level 3. Those are the typical kind of ear loop or tie face masks. Yeah. Many tie masks many tie masks, like old school cone masks for dentistry, do not come in different varying levels. It's typically amly ear loop masks that have an ASTM level, and that's level 1, 2, or 3.
Yeah. But the biggest difference on those has to do with the amount of saturation, isn't it?
It has to do with the bacterial filtration rate, which is the BFE of it. And so, for level 1, it's 95. And then for a level 2, I believe it's it's not much greater. It's a 97-ish. And then a well-fit level 3 is closer to an N95, but by its very nature, it doesn't have a facial seal, and it doesn't have the pull in two different areas on the mask, because an N95 mask has two different straps on it, one that goes to the crown of the head and one that goes around the base of your neck, and that actually pulls a greater pull.
I've been seeing people flip the ear loops around lately. Like just now,
Well,
I've never noticed that before. I'm like, what? Even at the grocery stores, like the cashiers have the ear loops flipped to, which probably does nothing to add any protection for those.
Well, it actually makes less protection, because
really?
when, like, if they take the we're talking about the ear loop and then they cross it and then put it around their ear, so it's in an X instead of just going around the ear, what that actually does is it pouches or causes a pleat in the side of the mask, and that creates direct air entry. And so I get into fights with people, instructors who come onto our clinic floor all the time, and I'm like, nah, you want to work here? That's not okay, because
I've never seen it before. I just started seeing it yesterday and today.
The question
I think
it's not right.
I want to just get back to Graham on the issue of screening, because you had a point that you wanted to make.
Yeah, I agree with Rona. Like, one of the really important things is what audience are we talking to? So in the general dental world, I agree with her. If they're not equipped, not trained, don't have proper PPE, not fitted with N95s, that's a really big part of the discussion. If we're talking about oral surgeons, in Alberta, it's a pretty simple discussion. There's 10 or 12 of us here and 10 or 12 of us in Edmonton. Whereas in Brian's situation, there are 300 or 400 oral surgeons in Ontario that could be a helpful part of this process, especially in the management and triage, like in that role. So even if there's a total ban on AGMPs, which is actually I'm not against, and certainly saying, whether you should or shouldn't have N95 protection or respirators or any of those things, doing swabs as part of the assessment protocol. As far as like seeing the patient and assessing them, that can be done with gowns, hats, masks, shields. Even our nurses are taking care of patients on COVID wards with that type of PPE. They're not everyone on the ward is wearing N95s just for, regular old sort of travel around the ward. So there is still a role for people to participate in like the assessment and triage more than just telehealth. But, other people might have different opinions on that.
As we start to wrap this up, I'd like to reiterate a couple of things that, the Canadian Association of Oral Surgeons is certainly very sensitive to the fact that we do primarily, we run businesses. Some of us are involved in academic programs, and there are significant ramifications at an academic level for our residents' lives and their educational processes. But I think I'd like to reiterate one thing that Brian said, is that we are particularly sensitive to the plight of our employees and the economic impact, as in the rest of society, and we're very empathetic to that notion. And we certainly hope that on the other side of this, we can ramp things up and maybe have an economic correction for our employees specifically on this issue. Graham, you wanted to make a comment regarding dentistry, I believe.
Yeah, I just think that, in our role at CAOMS, so if I just put that hat on right now and what we're doing right now in this forum, I would echo what Rona just said, in the sense that this forum is more advocacy for our members. And so for all of our members that are out there and that have roles in hospitals, in these clinics, on committees, that concept of what Rona described, of the types of work that we do and where we do the work, anatomically where we do the work, is really important, that oral and maxillofacial surgery and dentistry doesn't get left out of the discussion, compared to our anesthesia and ENT colleagues who might work in the hospital more frequently and are being offered potentially some levels of protection, like whether that's in the PPE environment or whether it's in the pre-screening for surgery discussion, which is what we talked about swabbing before surgery. There's discussions around CTs before surgery. There's lots of safety discussion around it. And I think that that's what we want to focus on for CAOMS, is let's be a part of the safety discussion, and then realize as we make those recommendations forward to hospitals and institutions, they're going to take it into context of their supply lines and facilities.
Right. Good point. Very good point. On the subject of the CAOMS, I want to reiterate the fact that those of you that have been listening to this conversation understand that we are not representing a regulatory body. The nature of the conversation here has been one that we hope you'll find of interest in the evolution of this fast-moving scenario that's affecting our communities. We just hope this information will be of some use to you in your day-to-day lives as you sit there and occupy your time with things other than your clinical practices. I think for me, the biggest take-home message is be extremely selective about the emergencies that you see. I think that as oral and maxillofacial surgeons, we certainly have, as Graham mentioned, a role to play in very safely assessing these patients and making triage decisions that will selectively send patients down the line to the centers hospital centers that need to manage them.
And very, very quickly, one request. In about 2 to 3 weeks, if projections are correct, Ontario's capacity for ventilated patients is going to be exhausted. I've been working over the weekend with a number of groups, including OZOMS, our Ontario Society, the Ontario Anesthesia Society, the Ministry of Health, Critical Response Team, to try and put together a database of those who have ventilators or anesthetic equipment in the community. And we got it up and running yesterday to some levels, today full blown. And I would encourage every provincial oral surgery group to create those databases and share them with your ministries of health, because unfortunately the reality is that equipment is going to be needed in some way, shape, or form. And so I just wanted to put that plug out there. For those of you in Ontario watching this, please fill out the Google form that was circulated today.
Okay. I believe a comment from Graham is that Alberta has undertaken a very similar activity, and I think it's a fantastic initiative. Brian from Toronto, Graham from Alberta, and Rana, I'd really like to thank you for taking the time to participate in this exercise. I wish everybody on the CAOMS who's listening to this well. I hope that you and your families stay in good health. I know I think that we have some difficult times ahead of us, and hopefully we'll come through this on the other side and be able to enjoy some sunshine later on in the year. Thank you once again for your participation, and hopefully we can have another chat about this as things progress down the line. Thank you once again.
Thanks, Tony.
Thank you, Tony.
You guys.